Thank you. I just want to check that you have the slides and you're comfortable sharing them.
You mean Theo's slides?
The introductory slides.
Oh, no, I didn't download them, but I can.
Whatever's easiest.
Unless you, yeah, sorry?
I can also share it from this side, whatever is easiest.
That's fine. That's fine.
Cool. Hi, Theo. How are you?
Hello, how is everyone?
Good, good. Really enjoyed your talk on Saturday, and we get to hear you again today.
Oh, sure.
Do you want to share your slides? Are you comfortable?
I can do so. Sorry, I'm just quickly share. Are you able to see that?
Yes, can see it nicely.
Good.
Okay, perfect. I'll share the intro video until 4 o'clock and then I'll hand over to Candace.
Okay. And there's a poll, hey?
Yes, that's for the beginning of the session, right?
Very beginning.
Perfect.
Good afternoon, everybody. I see we've already got almost 70 participants online, and we want to make good use of the time, and therefore I don't think we really need to wait much further. So I just have a few sort of housekeeping matters to take care of before giving you over to Theo. Why is it not going? Okay. All right, today's deep dive is brought to you by Blood SA and Aspen, which is in strategic partnership with Sashas and Sassit. So thank you very much. For those who don't know, the deep dive management team who put all of these wonderful sessions together and are in charge of all of us to make sure it all runs smoothly. It's Professor Stelferberg, Gerdien Krutzinger, and Nicole Smith. So just so all of you know, we do record these sessions. I think the majority would know that because you attend regularly. And if you want to gain access to the recordings, please go to bloodsa.org.za under resources, deep dive. And while Theo is talking, if you have questions and you don't want to speak yourself, you can put it in the chat box and we will catch up with that at the end of the session. The session is CPD accredited, but you have to attend for 1 hour. So please remain online and ensure that you put in your correct HPCSA number in order to get your CPD points. All right, if you want to join the mailing list, please go to the website under resources, say subscribe to Deep Dive, or you can use the QR code that's on the screen now. And please fill in the feedback session after the meeting, which is always very nice to provide feedback to the speakers after the presentation. Right, this is also a HHT Horizons conference at Century City taking place in Cape Town in September. So the conference registration link will be in the chat for those who are interested. Okay, so we will have just the talk by Dr. Theo Gerdner today, after which we'll have a Q&A session, and then we will close. This is a hot topic, so I suspect there will be lots of chatter afterwards. Okay, so let me go ahead and introduce Theo. Theo is a hematopathologist, qualified at the University of Cape Town, followed by a clinical hematology certificate. So he is a clinical hematologist, although he's the lab guru. He's been associated with Albert Cellular Therapy and Oncolab in Pretoria for the last at least 10 years. I think it may be more. His primary interests are flow cytometry and genetics. And for those of us who know Theo, we know he doesn't like warm weather. He walks in slip-slops the entire year. And he's also the go-to person and the kind of person you can call any time of the day and night with problems. And he's always there to assist. So thank you, Theo, and we're really looking forward to a fantastic session. Thank you.
Good. Thank you very much, Candice. Can everybody see my screen?
Yes, we can. Thank you.
Okay, cool. So firstly, I would like to thank Aspen for having me here. And then I also want to thank Candice Hendricks herself for providing some of these slides and information. I'm not a pediatrician, so that was very kind. So today's talk is going to be very simple. Candice says it's a hot topic. I'm not sure that I agree with that myself, but I would like your opinion. So we're going to start with an opinion poll. And then we're going to briefly go through the history of MRD testing methods. This is not a technical talk on the ways of testing MRD or any of the laboratory things. Few slides on adult B-ALL, few slides on pediatric B-ALL. So as you can see, we are focused on MRD in B-ALL, although the tenets are basically the same for other diseases. There are some important things to distinguish. Okay, so I see that people have already started answering my first question, which is, the presence of MRD is an adverse prognostic feature irrespective of the actual level of MRD. So is it more important to be MRD positive or negative, or does the level actually make a difference? Okay, so most of the people, it seems, agree that the
Or strongly agree.
yeah, or strongly agree. Okay, so we're saying that MRD is bad no matter what the level. Okay, that's a good thing. We'll get back to that. About a quarter of people disagreed. So I'm going to end this poll and go to the next one, if that is okay. Good. So my next question is, the presence or absence of MRD should be used to optimize I can't see my question. Sorry, let's quickly go to.
All of the questions are in one poll. Can I
Oh, I'm
share?
so sorry. And now I've
No
stopped the
worries.
poll. So sorry.
No
Relaunch
problem.
it. There we go. Thanks. Oh, now I've taken away your answers. I'm so sorry. You'll have to poll again. The presence and absence of MRD should be used to optimize or adjust the management of patients with BALL. Do you agree or not? So if there is MRD, do these people have bad disease? And no matter what you do to them, they still do worse? Or can you actually act upon this and improve their outcomes? Okay. So most people agree or strongly agree that we should
Wait,
change.
I think this is still the number one.
So
No,
if
no,
you,
this
Because we relaunched. So
if
can
you
we go to the
scroll over,
second?
I am
yeah, so
at the
if you
second
scroll down,
one.
you can see all of the questions.
Sorry. So you need to scroll
Ah,
down.
I see. Okay.
Okay. Then the third question, therapeutic intensification can overcome the adverse prognostic effect of MRD. So this is always the question, is the disease inherently bad? And by giving more treatment, am I going to overcome that inherent poor prognostic effect? Okay. And then my last question, MRD testing is only viable if the drugs to manage a positive result are readily available, as in developed countries. Okay, I'll give you a while longer to answer. We're still waiting for quite a few participants, and then I'll share the results. I can't say that I will have the answers for you to any of these things today. Okay, we have about 27% of people answered. Candice, shall I leave it at that or give a while longer?
I think this is anonymous, so please go ahead and answer all the questions. Give another minute.
Okie dokes.
We won't see your
No.
name.
Yes.
It's just vote. We're all here to learn. I myself am not even sure of the answer to all of these questions. Okay, it's going up. We're getting to almost 40%.
Good.
Okay, I think let's stop there.
Okie dokes. Good. And I will share the results if anybody wants to see that. Okay. So the history of MRD. So we knew that especially in pediatric lymphoblastic leukemia, that the assessment of response by morphological review at day 14 of therapy was prognostic, and they had these three morphological response groups. So the first was fewer than 5% blasts, which had 63% event-free survival at 6 years. M2, 5 to 25% blasts, 44% event-free survival, and then M3 more than 25% blasts, which had dismal outcomes. But we knew as well from admixing studies by mixing leukemic blasts into normal marrow, they could calculate that even a patient with an M1 response, so a morphological remission, still had a remaining leukemic burden of between 10 to the 10 to 10 to the 12 malignant cells, and we could not detect these by morphology or routine methods. So people started using cytochemistry, karyotyping, and cell culture methods, which yielded a modest increase in the sensitivity in selected cases. And then we started with interphase FISH, which could detect down to about 0.5% of MRD in cases that had a FISH target that we could detect. MRD was, however, only really detected to clinically relevant levels of 10 to the minus 3 to 10 to the minus 4 with the recent advent of flow cytometrical methods and later also PCR. And nowadays in lymphoid or ALL malignance, ALL, we can detect NGS to levels as low as 10 to the minus 6. So how important is this? This was a seminal study that was published by the Children's Oncology Group. They evaluated or reported on 2,143 children with B-ALL. They evaluated MRD at day 8 on blood and day 29 on marrow using flow cytometry. And you can see that this clearly stratified patients into different risk groups and event-free survival probability, where the patients with MRD more than 1% had very poor outcomes, and those who were MRD negative to a value of less than 10 to the minus 4, very good outcomes. So MRD definitely is an important thing to measure and to determine, and it will determine how your patients will do. Interestingly enough, there was less distinction between high and low level MRD, this 59% and 49%, but it is still important. Then, if we look at another study from the Children's Oncology Group, this was 619 patients with B lymphoblastic leukemia, and they were monitored by both next generation sequencing, or what was then called high throughput sequencing, and by flow cytometry. And you can see that the two methods are very equivalent. The overall survival for MRD negativity, less than 0.01%, are virtually the same for both methods, and then virtually the same for MRD positivity. And this is event-free and overall survival. It correlates extremely well. There are, however, discordant cases reported by the same study, and we can see that most of the discordant patients were flow negative, NGS positive, and this is due to the generally lower sensitive or higher sensitivity of NGS methods compared to flow. So there are some patients who will be negative by flow, positive by NGS, and they typically have an intermediate event-free survival compared to the dual positive patients or the dual negative patients. So if we look at the different ways of testing MRD, we know flow cytometry very well. Its sensitivity can go down to 10 to the minus 5 with some of the Euroflow assays. Some people claim to have pushed it further, and the more colors you add, the lower or the higher your sensitivity becomes, the lower you can detect. It can be used for the vast majority of ALL patients. It is rapid, and we say that it has limited standardization. This is no longer the case. There are standardized CE-IVD approved assays available today to use. So the standardization has come a long way, and it gives you a very quick answer, and it is relatively cheap. Then we have PCR for the immunoglobulin genes, or the T cell receptor in TALLs. The vast majority of patients with ALL can be monitored. This is a very sensitive technique, 10 to the minus 4 to 10 to the minus 5, but it is hugely time consuming because PCR primers have to be designed for each and every patient. You have to do patient or individual assay validations, and then you're basically designing a PCR assay per patient. So this takes very long. Once it's up and running, it's fairly quick to do, but the initial work is a lot. Then there's PCR for genetic abnormalities such as fusion transcripts. This has limited applicability in pediatric ALL, slightly more in adult ALL due to the higher incidence of BCR-able transcripts in this patient group, and it has very good sensitivity and specificity. Unfortunately, yes, this is not for all patients. And then there is NGS. So NGS is similar to the PCR for the T cell receptor or B cell receptor or IgH complex. It's very, very sensitive. It can go down to 10 to the minus 6. It is becoming widely available. The problem with this is it is quite expensive, but not so much the expense as the time consuming. So it takes about 2 weeks to get a result, whereas flow cytometry should take a day or two to get results. This takes much longer, and thus the clinical applicability of this method has to be carefully considered in terms of where you are in your treatment protocol. But it's a very sensitive method, and definitely one that one would use at important time points. So then lastly, just tips and tricks for MRD testing. We do need a good sample quality, and less is more. We don't need 20 mils of bone marrow, but we do need bone marrow, a sample that is representative of bone marrow and not hemodilute. So we say usually the first pull, or one has to go in a second time and pull it to avoid hemodilution. The timing of MRD is important, and it is protocol dependent. So you should know what has been clinically validated in your protocol. So the NCCN guidelines recommend at the end of induction and consolidation at a bare minimum. There is also good data for pre-hematopoietic stem cell transplant assessment of MRD, and then usually any patient after allogeneic stem cell transplant should be negative at any time point. So flow cytometry, we said, is rapid, slightly less sensitive. One can also look at the blast clearance in peripheral blood at earlier time points. There is good data for AML in this type of testing, but also for BALL. NGS, more sensitive, but slow. There are limited studies looking at cell-free or liquid biopsies on peripheral blood, and they do show promise in detecting MRD, but this is not yet standard of care, so we still use bone marrow. And they say the minimal sensitivity of an assay should be 10 to the minus 4, which most assays these days reach with relative ease. However, the caveat, once again, if your sample is hemodiluted, you may report a sensitivity of 10 to the minus 4, but that is not true because your sample is not representative of marrow. So ideally, MRD reports should give an indication of the level of hemodilution, and there are different ways to do that. Yeah, that's a talk for another day. Then if we look at MRD in adult BALL, this is a meta-analysis published in JAMA of 39 studies. For the adults, less data. So the event-free survival over 10 years, 16 studies with 2,065 patients. Patients who were MRD positive compared to MRD negative, and you can see there is and this is at any time point, you can see that there is a massive difference in event-free survival, and that also pans out to overall survival, fewer patients still, 5 studies with 806 patients, and a huge difference once again in overall survival. So this meta-analysis had a total of 13,637 patients. The rest of them were pediatric patients. The MRD cutoff was 0.01% or 10 to the minus 4, and both flow and PCR were used. We will look at the pediatric data a little bit later. If we look at the subset analysis, disease stage, the timing of MRD before and after transplant, the MRD level, where the MRD was tested locally or centrally, and the methodology, flow or PCR, none of it made any difference. Everything favored an MRD negative result. But the one that was strongest in favor of an MRD negative result is post stem cell transplantation. This makes absolute sense because any level of disease following stem cell transplantation is bad. What is important to note here is that the level of MRD negativity, 10 to the minus 3, minus 4, or minus 5, carried less weight than the MRD negativity itself. And then MRD negativity before stem cell transplantation also appeared to be important. This is a German multi-center study for adult ALL. These were 580 patients who were in complete remission, but with evaluable MRD. It was tested by PCR, and they measured the probability of a continuous complete remission with and without molecular failure. And you can see the patients who had a molecular failure but remained in complete remission also did far worse than the patients who were in a molecular complete response. They stayed in a continuous complete remission. And then so the second graph in this excluded patients who underwent stem cell transplantation after the CR was reached. So you can see those patients who were in a molecular failure and did not receive a stem cell transplant did even worse. So the 5-year overall survival in this first chart for those patients who had a molecular failure was 33%. Whereas it was only 12% in the second group who were not consolidated with a stem cell transplant. So this shows us that even patients who have a molecular failure or MRD positive, a significant subset of them can still be salvaged by stem cell transplant. So while it is better to be in a molecular response when one goes into a stem cell transplant, it does not mean we should not transplant those patients who we cannot get into an MRD negative state before transplant. Okay. Then this is a study from Fred Hutchinson. It's 160 adult ALL patients who underwent allo stem cell transplant in the first complete response. So they divided the patients up into MRD positive and MRD negative patients with a level of a detection of sensitivity of 10 to the minus 4. And one can see the probability of relapse-free survival and overall survival is significantly different for those patients who were MRD negative and MRD positive. So it just once again shows an MRD negative state before transplantation is obviously favored, but that once again, it doesn't mean that we shouldn't transplant the patients who are MRD positive at that time. And for this study, they only used multicolor flow cytometry. Then I'm going to go to the BLAST study. This is a bit of blinatumomab data. So the BLAST study was an adult study. It was patients older than 18 years who had precursor B-ALL or B lymphoblastic leukemia, and they were in a complete hematological remission, but they were MRD positive, defined as a level of more than or equal to 10 to the minus 3. And the minimum assay sensitivity was 10 to the minus 4. They had to have fair counts because they were in a complete hematological remission. And then obviously the exclusion criteria were circulating blasts, extramedullary ALL, CNS disease, a prior allo stem cell transplant, and recent chemotherapy or radiotherapy. So basically, well, MRD positive ALL patients. The primary endpoint of this study was the rate of complete MRD response after the first cycle in the primary endpoint set. And then the secondary endpoints were relapse-free survival amongst Philadelphia negative patients, the duration of complete MRD response, overall survival, and the duration of hematological remission. So how they treated these patients, they gave them the first cycle of blinatumomab, then measured their response, and then they stratified patients into two groups, those eligible for allogeneic stem cell transplant, who received up to 3 additional cycles and then was transplanted whenever the donor was available, or those ineligible for allogeneic stem cell transplants. They just gave them 3 more cycles and then did a 2-year and a 5-year follow-up. And this 5-year follow-up has been published, so the final analysis of the BLAST study. So the complete MRD responders, so those patients who became MRD negative and these are adult patients, I just want to reiterate, so patients who became MRD negative following blinatumomab administration, 45% of those, 45.9, who were MRD positive and became negative and subsequently had a hematopoietic stem cell transplantation were still alive at 5 years. You can see in those, the group that did not have, the yellow bars, did not have hematopoietic stem cell transplant, 60% of patients relapsed. So this is not good. So the bottom line here is that we should try and consolidate these patients when they do respond with an allogeneic stem cell transplantation. But, and if you look at these middle bars, died without relapse, there is significant toxicity associated with stem cell transplantation in this group, which we fully know. Okay, so the non-relapse mortality is much higher in this group, but they do still benefit, and there is significant 5-year overall survival or relapse-free survival at 5 years post-transplant. Then if we look at all patients, so this includes the patients that did not attain an MRD negative state, much higher rates of relapse if they weren't consolidated with an allogeneic stem cell transplant. 72% of patients relapsed. There is, however, 40% of patients, even with a hematopoietic stem cell transplant, were still alive without relapse at 5 years. And then what is interesting is if one looks at the MRD responders, 30% of them who did not receive a stem cell transplant in complete cytological response, versus 19.4% of all patients, so those who did not attain a response, were still alive without relapse at 5 years after the trial. So this shows us that obviously it is best to consolidate these patients in who after blinatumomab therapy, to consolidate them with an allograft, but there is a significant proportion of patients who will benefit just from receiving blinatumomab. Even if you cannot transplant them, there's still a significant percentage of patients who will be salvaged. Okay. Then I'm going to continue to pediatric ALL. So this is that same JAMA study. You can see the numbers here are much larger. There's event-free survival after 15 years for 11,249 patients based on MRD, and you can see once again a massive difference in event-free survival if a patient were MRD positive versus MRD negative, and that also pans out to overall survival. Once again, long-term data, 2,876 patients, and there's a significant difference in overall survival in the MRD negative and positive patients. So MRD definitely in pediatric and adult ALL is extremely important. Infant ALL is a different story. We know infant ALL patients have high rates of KMT2A or MLL rearrangements. We know that these patients have often mixed phenotype, acute leukemias, and that they respond very poorly to therapy. We do know that infant AL, acute leukemia patients often fail to even reach a CR, so they do not get to transplant. And there are different treatment protocols available for them. So the idea of adding blinatumomab to these patients' treatment protocols was to basically try and get them into a CR1 so that they can go to stem cell transplant. And there are different guidelines here. We will look at some of the outcomes now. But as you can see, the Interfant 6 has upfront, well, just after induction, they get consolidated with blinatumomab. And then after further consolidation chemotherapy, they go to a stem cell transplant if they have MRD positivity. And then the UK guidelines also include blinatumomab up front, and then based on whether they still have MRD positivity, they will, and the level thereof, they will go to a stem cell transplant or to a CAR T. And the same with the Interfant 21 trial. All of the patients get blinatumomab, and based on MRD stratification, they will also go to a stem cell transplant or a CAR T followed by a stem cell transplant. So typically, or historically, the outcomes for infant acute leukemia has been dismal. These are some of the trials that have been reported, small cohort sizes, and you can see the rates of stem cell transplant in CR1 differ, but and the rates of KMT2A event-free, rearranged event-free survival and overall survival differ markedly. What is important to note here is the Interfant with blinatumomab, and above that, this JPLSG, which is MLL10 Japan study. These have vastly superior overall survivals reported in their groups, even though the Interfant 06 and blinatumomab follow-up is only 2 years. The Japanese study was 5 years. And the major differentiating factors here was that Interfant administered blinatumomab. The JPLSG MLL had the highest rates of stem cell transplantation of any of these studies. And so it seems that the addition of blinatumomab followed by stem cell transplant consolidation can markedly improve the outcomes for these groups of patients. So if we look at MRD in childhood B-ALL, this is just follow-up from the Rialto trial. So pediatric patients between 1 month and 18 years of age, they had 110 patients with relapsed refractory ALL patients, and they gave them blinatumomab therapy. And as you can see by MRD response, those patients treated with blinatumomab, which turned MRD negative, had significantly better survival, overall survival, than those patients who failed to go MRD negative. Then in this same study, if they looked at allo hematopoietic stem cell transplant, post-blinatumomab administration. You can see that those patients who was consolidated with an allogeneic stem cell transplant, significantly better overall survival after stem cell transplantation than those pediatric patients that did not receive a stem cell transplant. And then this is a current BFM protocol for pediatric B lymphoblastic leukemia therapy. I'm not going to go through this protocol. It seems incredibly complicated, but what I would like to point out is that the patients are stratified routinely. Here at MRD time point 1, they will be stratified into high risk or non-high risk patients. Then at MRD time point 2, they will be stratified into standard risk, intermediate, high risk, and then the high risk, then the intermediate risk will receive blinatumomab. The high-risk patients will also receive blinatumomab and then will be stratified according to MRD level again, and will either be stratified to an allotransplant or maintenance therapy, but most of the patients will go on to receive an allotransplant following blinatumomab exposure. And then almost my last slide, we often ask about the cost of MRD testing because it's not insignificant. So this is interesting. I Googled a bit about MRD testing and cost considerations. So the financial implications of MRD testing was determined in several countries, including the UK, Germany, Canada, China, Australia, and New Zealand. But funnily enough, even though MRD testing in ALL has been performed for a very long time, people look at the cost of MRD testing mostly in the setting of multiple myeloma, or plasma cell myeloma. And I'm not entirely sure why this is, whether people are more comfortable in asking the question of what does it cost in an elderly population cohort, such as plasma cell myeloma populations, and whether they are more uncomfortable asking this question in pediatric populations. But the one that I could find was this in Ontario Health Quality Assessment, and they looked specifically at minimal residual disease evaluation in childhood, acute lymphoblastic leukemia, and their conclusion, as with all the myeloma studies, were that it is cost effective. Roughly 50% of the studies that looked at MRD testing across the spectrum of hematological malignancy, so mostly plasma cell myeloma, found that it was not only cost effective, but cost saving, so that it would be cheaper to perform MRD testing and tailor one's treatment according to one's findings, and this specifically in the era of high-cost drugs such as blinatumomab, but also the myeloma therapies becomes an important thing. So you can actually, by choosing your drugs according to your outcomes and your results, MRD testing will save you money. So in conclusion, MRD testing is a prognostic tool that is applicable to the majority of hematological neoplasms. MRD testing in B-ALL is the strongest risk predictor of relapse-free survival, and it supersedes all other risk factors, genetics, everything in retrospective reviews. MRD testing and timing should be protocol specific, but is of prognostic value at any stage in the disease management after the end of remission induction. In B lymphoblastic leukemia, there is good evidence that the high risk of MRD positivity can be mitigated or partially overcome with early treatment intensification, specifically with regards to blinatumomab and hematopoietic stem cell transplantation. Hematopoietic stem cell transplantation and CAR T therapies are dramatically improved upon when preceded by blinatumomab-induced MRD attainment. We also are seeing this with with the CAR T therapies in lymphoma trials. The vast majority of these lymphoma trials will now include a salvage therapy or something to reduce the disease burden prior to the CAR T therapy, because we know that CAR Ts, as with hematopoietic stem cell transplant, is far more effective when you can get the level of MRD low or undetectable. And then MRD testing has been proven in multiple analyses to not only be cost effective, but oftentimes cost saving. So that is the end of my talk. I see there are some comments. I would just like to go back to my poll. So initially I said the presence of MRD is an adverse prognostic feature irrespective of the actual level of MRD. Most people strongly agreed there. In light of this data, I would say that I agree with that as well. So any level of MRD is prognostic, although there are minor differences between the different levels of MRD. Okay. Then my second poll was the presence or absence of MRD should be used to optimize and adjust the management of patients with B-ALL. Most people agreed there, and I think that most of the protocols, especially the pediatric ones, are in absolute agreement with you that this is the way ahead. We change our therapy based upon the MRD. Therapeutic intensification can overcome the adverse prognostic effect of MRD. There were more mixed responses, so about half of the audience was unsure or disagreed. I do not know well, I think the data is there that shows that at least partially we can overcome the adverse prognostic effect of MRD by giving blinatumomab and getting those patients MRD negative and then consolidating them with an hematopoietic stem cell transplantation. Those patients do very well. And then we do know that there are patients who, even if they do not become MRD negative by blinatumomab intensification or salvage, they will still benefit from hematopoietic stem cell transplant. And we also know that patients who do not have hematopoietic stem cell transplant options available, there is still a subset of those patients who will benefit from blinatumomab salvage, although the two together are optimal. And then lastly, MRD testing is only viable if drugs to manage a positive result are readily available, as in developed countries. There we have a split in the audience. Here I would say I disagree with this statement, because we do in the state sector still have hematopoietic stem cell transplant available. We have DKMS and SABMR who are working very hard to ensure access of all patients to this. So definitely, I think if you have stem cell transplant available, then there is still value in MRD testing. And with that, I am going to stop sharing and take some questions, which I don't know how to do. Oh, here's the chat. Okay.
Yes, there are some questions in the chat, Theo, starting with Esther.
So with Estelle, what MRD protocols do you follow in your institution, and what are the must-haves or wish-to-haves that you would like to integrate in your protocol? So we use, for most of our fit younger patients, we use Dana-Farber therapy and intensification. So we will test at day 21 post induction therapy. We test MRD on our B-ALL patients. And then we will do testing again at the end of consolidation. And during maintenance, we usually test them every 3 to 6 months. Obviously, if we do have an allogeneic stem cell transplant option available, we will test again at just prior to stem cell transplantation, and then we test at 6 and 12 weeks following allogeneic stem cell transplantation. We also do chimerism at that stage testing, and we will then it becomes more clinician dependent, but usually at 6 months and 12 months post transplant, we will still test. At the moment, we do flow cytometry for MRD testing, we do not use the Euroflow protocols because we opt for a multi-color panel approach. So we have higher color flow cytometers than the 8 colors used by Euroflow. So we use an in-house panel. We are also busy validating with very good initial results the NGS assay for the B-cell receptor. So we did our primary runs just 2 weeks ago, and they looked brilliant. There are a few caveats which we still need to sort out, but we will probably use NGS going forward. Once again, flow gives us a quicker answer than NGS will, but the NGS from our initial testing, it's not that difficult an assay to interpret. It's not like a myeloid MRD or something. Okay, then
That's
Jacques.
great.
Yes.
Yeah, I see Karen has an answer about your NGS. So you would do a marrow every 6 months in a patient on maintenance.
Yeah, usually. And then end of maintenance, we will do
Good
again.
point, which I think because we have intensified our treatments, but yeah, it's a good point to be sure that we keep on doing that.
Yeah.
Wow, NGS, well done. It was a lovely talk. Wow. Thanks, Theo.
Thanks, Estelle. Okay, Jacques Maladba asked, are there any data for improved outcomes with other forms of intensification apart from BLINA? That's a very good question. And I have never really been, I haven't been able to find much data. I think in pediatrics there is, and Candice, you must correct me, but the pediatricians have used intensification based upon MRD for a very long period of time. In adults, I don't find much data. And I mean, we are always driven to intensify if we find that there is still disease, but whether we overcome the inherent risk of the disease not responding to therapy with giving more chemotherapy, I don't know. The only outcome that is improved with intensification, or the only intensification that improves outcomes that I'm aware of, is allogeneic stem cell transplantation. But having said that, on the other hand, there's also good data that attaining MRD negativity, so which implies intensification prior to stem cell transplant, is associated with improved outcomes. I don't know, Candice, do you want to jump in there in terms of pediatrics?
No, I think there are many intensification protocols. We need to see just the latest BFM ALL, but I don't think any of them are giving the same results that blinatumomab is giving, and that's why it's sort of becoming standard of care. If you have an intermediate or high risk patient, it's because of the extremely good results that it almost seems just unfair to not provide that to a patient. We know that this is not possible in state at present, but we've just had a PEDS workshop on the weekend, and I had one discussion where we said we actually need to motivate for it. I think the results that you've shown, I mean, every study is just actually putting more of the nail, I don't want to say in the coffin, that seems wrong, but I mean, it's just actually telling us that if we don't have access to blinatumomab, we can intensify all we want. The outcomes are never going to be the same. So yes, as you said, transplant is a good intensification, but we're not going to get the best results.
Can I ask on that, Candice, would one not be able to motivate and state, at least for the infant leukemias, because you use virtually none of the drug, you can get them to transplant?
Yes.
I mean,
no, absolutely. I think we have to motivate for it, and we also have to try to get the pharma companies to provide it at a lower price. I mean, it's the price of blinatumomab at the moment is the cost of a transplant. We are struggling to just get the cost of the transplant. So, I mean, to get to transplant, fine, but yeah, blinatumomab is a major hurdle, but I think certainly as a pediatric group, I think we need to motivate for it. It's the infant ALL in particular. Alan, I see Alan's hand is up before we go to the rest of the chat. Alan?
Yeah, there's a couple of comments. Be lovely to have Blinner. It's a game changer, no question. And we're behind the curve again because now CRG, Sumit Gupta and Mignon Loh have published the CRG data, and it's coming out of Europe as well, the BFM. Everyone's using it upfront now for everyone. So now we're gonna induce with Blinner. So I'll give you some perspective. If and I'm not going to give you all the numbers, I don't want to waste your time. That the cost per cycle is about 84,000 euro. You got a currency converter on your iPhone. You can figure that out. So if I gave every BALL patient that new CRG approach, that's my whole budget for the year. That's it, my entire budget. So unfortunately, the reality is that the current pricing, Blinner, is out of our grasp, quite clearly. And they're not analogous instruments, Theo, because although I've seen some nasty neurotoxicity, and I'm sure a lot of people have with Blinner, some nasty cytokine release syndromes, the fact is that nothing beats a 5% transplant-related mortality. And we now have, I want to just say, we have a much more layered problem. So one, the unaffordability of Blinner, and two, not all transplants are the same. Not in my house. Maybe you guys are better at haplos, but I have a long downstream tail from haploidentical transplant of people with chronic GVHD and problems, and there have to be different criteria. So one of the uses for the MRD, like both the depth and the I mean, measuring it and also measuring the depth at different time points is the ability to make a transplant-related decision. Because there may be a patient who, so when you say intensification, for us, it's about which risk protocol we apply. Now, our very high-risk protocols on BFM and CRG are extremely toxic and very hard with adults, but we kind of manage to get through them in kids. And I think we have to have slightly different thresholds for making that. But this is what our transplant group's obviously busy sorting out for making those transplant decisions. But I will pop that Mike Pulsifer paper in the chat. Mike Pulsifer and a bunch of other guys looked at all the different groups and what their opinions were on different risk factors, things like BCR-ABL or ML. I still say MLL because it's quicker, right? And how they would influence the transplant decision depending on two things. What was the available transplant and what was the depth of remission? And that then, makes you make a decision about first or second remission transplant. Once you're in second remission, you either transplant or it's game over. But I mean, so it's a very complicated landscape. And Candace, I echo the last part of your statement. They need to give it to us, not give it to us. I'm not asking anyone to give it to us, but they need to price the drug in a range that's affordable. I mean, the pricing it's actually deplorable. I'm going to shut up now. Thanks, Theo, for a great talk.
Cool. Thanks, Alan. Okay, Estelle asks, what's the access to Blina in private practice? Estelle, that depends highly upon one's medical scheme and option and things. We do get it. Obviously not easily and without a fight. And probably we are giving it way too late after we've tried salvage chemotherapy and other things. So I mean, we had a compassionate use program before it was registered, and even there we didn't see the brilliant results that we saw elsewhere. We were using it for lymphomas and things at a higher dose, and the side effects were more. But B, we were probably using it way too late into the treatment cycles to see the magnificent results that they are seeing elsewhere. But we can get Blina.
As you know, now in Philadelphia positive, the studies are actually now about giving it up front.
Yeah.
So it's been approved in maintenance or whatever you want to call it, consolidation. What would I know? I don't use it. It's been approved in that. It's been approved in relapsed refractory, but they are now doing studies to see if it, for the frontline treatment. So, and that's probably going to be very, very good. And that's just one way. And the effect in other ALLs, I'm not really so sure. The different other types, but yes, it's going to make a huge difference.
Yeah, no, I agree. So Karen asks, how has NGS with a further 2 log sensitivity affect these results? Can't just report MRD positive, negative. So the studies have mostly been performed with a cutoff of 10 to the -4. But what I can say of the myeloma stuff, the deeper we start testing, the more we find that it is still of prognostic significance, even a lower level of MRD and a lower level. So I suspect the same will pan out for this. As the data showed here from that one trial, the JAMA thing, the meta-analysis showed that any level of MRD down to 10 to the -5 in that trial was statistically significant and had an effect. But if one does large studies, there will probably be different prognostic values for a 10 to the -3 versus a 10 to the -4 versus a 10 to the -6. But I don't think a 10 to the -6 is insignificant. And definitely all the guidelines for MRD reporting at present say you should quantify absolutely the level. With regards to MRD, could you perform on peripheral blood? Yes. So long ago already, these studies were done, and we know that TALL and CLL, there's good correlation between the blood and the bone marrow. BALL and AML, you seem to have a log level lower in peripheral blood than you have in bone marrow. So bone marrow is still preferred and probably superior. Having said that, if you have NGS that can go down to a 10 to the -6, you can probably go and do a peripheral blood, a cell-free assay, not a cellular assay. So you look at cell-free, that we already do for solid tumors, and you can pick up with some, and there are publications about that, but I don't know of anyone that has routinely instituted that in the clinic yet. Cell-free NGS is a different talk for another day. It has a lot of caveats and things, but yes, that is probably where we're heading. Okay, then Jasmine asks, what level of MRD is considered acceptable prior to allogeneic stem cell transplantation in adult patients? So the studies 10 to the -4 has been what has been studied and reported on, and that's what we have data for. Lower than that, we will have to see. Then additionally, does current literature suggest correlation between the degree of MRD and the incidence or severity of GVHD? I am not aware of any such literature, but I do not know the answer to that. That will be an interesting thing to look at. Karen, the kit for our NGS is because we have a thermo platform, or our Illumina platform is not it's not good enough for this, but so we use Thermo and we use the Thermo kit, but mostly worldwide, Robin will tell you that people use the clonoSEQ assay, is the one that's widely used. They all work on the Biomed 2 primer sets. So they are highly standardized in between the different kits. The big thing is the quantification. You have to have a cell line that you've typed. So you have to, for a reference, you have to put in cell line material. If you are using whole blood and not sorted B cells, you have to go and look at what percentage. So there's a couple of caveats with NGS that you just have to get your assay. Initially, it's a bit of a steep learning curve, but once it's running, it runs fairly well. Prof. Poole says you do not have to transplant if MRD after Blincyto and infant ALL. That's a good point. I wouldn't be able to argue that. Does anybody have any comments on that?
I mean, if you look at the protocol, some of them still carry on and do it, but I mean, there, as you put up there are 3 different sort of types of approaches. And you know, in the UK, they intensify early and do the blina and carry on. And some don't. So I think we probably also need to reach consensus about what we do in South Africa. But I mean, if we can spare the patient a transplant by giving the blina, of course, I would be thrilled to do that, because transplanting an infant is no joke.
Yeah, unfortunately, the numbers of all the trials are so small that it's difficult to know. Deplorable, a good word to use for the price, okay. We must always factor in chemotherapy is not cheap. If we actually go and look at maybe in the state service, but if we go and look at in private at the prices of chemotherapy, and David Britton did all of this now with our CAR T trials, chemotherapy is not cheap at all, and obviously a stem cell transplant is not cheap at all. Okay. Ashraf said 39-year-old lady, Philadelphia, negative BLL, high risk, MRD positive post-induction at 0.1% Euroflow. Sorry. Again, post-consolidation, offered Blina 1 cycle. Is there any further plan for additional therapy prior to proceeding to stem cell transplant? I suppose if she had a partial response to blinatumomab, one can try some more, but I would think, yeah, you would
The
get.
MRD seems to have gone up post
Oh,
Blina.
I'm so sorry. I'm so sorry. I read a decimal wrong here. No, then I wouldn't waste time. I mean, I don't know, but my gut feeling says here you want to get to transplant as quickly as possible. Although an MRD level of 0.75 is actually an imminent relapse. So this patient probably has a very poor prognosis even with transplantation. In vivo scribe kit, Karen. Okay, yeah, that's lovely. No, that is, I mean, in vivo scribe has for very long dominated this this area of B cell receptor and T cell receptor testing. So I actually thought the clonoSEQ was their kit, but it isn't, according to Robin. But I mean, I've seen the in vivo scribe kits, and they sell the positive control and things, and the software goes and looks for your and works out your percentages and things. So they are very experienced in this. Yeah, so good.
Yeah, I have a question about the use of CAR Ts following blinatumomab. I mean, and we know it gets done, but tell me about the presence of a target. I mean, if you are using Blina and you are wiping out the CD19, you give CAR T. I just
so there is definitely data that patients still respond very well to CAR T after Blina. So the majority of blinatumomab refractoriness or patients who do not respond or suboptimally respond are still CD19 positive. So in our blinatumomab patients, I think the rate of CD19 negative relapses or refractoriness is about 10%. It's not a lot. So presumably there are other mechanisms for resistance, and those patients can still respond to immune effector cells. But I don't know that anybody has really untangled that group and seen. I don't know what the point would be to give a CD19 negative patient a CAR T, but there is definitely data for the other patients. Good.
Yeah, I mean, this is all. So would you, if your NGS panel is set up, you would change from a flow panel to an NGS panel for MRD? No?
Probably not, because we would have to discuss that with our clinicians. Not cost-wise, it's time-wise. Like, how quickly do you want? So we would probably implement a staggered approach whereby after stem cell transplantation, where you don't need an urgent result, we would change to an NGS because we want the higher sensitivity. But after induction, you can't wait 2 weeks to get a result from NGS. So there, upfront, we would still probably use flow.
And I know you mentioned that PCRs are very laborious as well. Should that even be pursued? I mean, if you're saying that flow is rather sensitive?
You get the same answer from the NGS that we would have gotten from the PCR. So I don't think anybody has the manpower in South Africa to do that PCR. I mean, those labs where they do it have 10 people just working on that all the time. We don't have the infrastructure.
What is the, so they are both quite labor intensive, but what is the cost difference? I mean, versus doing an NGS and a PCR, I mean, that would be relevant in the state sector.
The initial cost of setting up a patient-specific PCR is going to be extremely high. After that, it become cheap to run. And I mean, I think, Karen, maybe you can you can tell us. I don't know about the costing of PCRs in the state, but you will have to do, for each patient, you will have to do your sensitivities, limiting dilutions. You will have to run a full validation, and that PCR assay will only be for that
Yeah.
patient. So I don't think it's practical, but I don't know. Yes, I agree. It would be an absolute nightmare. Thank you. So NGS has really
So-
made that easy for us.
Okay, so we would still advocate that flow cytometry, being that it is quick,
Rapid.
should be the preferred method for MRD
Well,
testing.
if you need a quick answer, or if you are going to change your management quickly based upon that, yes. If you can wait a week or two for an answer and you want a much deeper, solid response, then NGS would probably be the way to go.
Yes.
And look, sorry, I'm talking as though BCR-ABLs don't exist. We still run BCR-ABLs all the time
Yeah.
for our adult patients, and that works
Yes.
very well and is quick and easy. But for the other 90% or so patients.
No, okay. I think this has been fantastic. As always, are there any other questions for Theo? I think, I mean, standardizing MRD is also extremely important. As a pediatric group, we are trying to standardize indications for transplant, and for all the MRD patients, we've had to say all MRD patients have to be referred, because MRD testing is very heterogeneous in South Africa. In the state sector, the private sector, it may be better, but I think it would be something to work towards, try and have some kind of a standard in the majority of the labs, so that we know, I mean, this is 4 colors, that one is 8 colors, you're running however many colors, it becomes difficult to try and ascertain what is actually MRD. And now we just like, okay, any MRD needs intensification, but as you say, the level of testing is different as well.
So just to interrupt you, I think at the very least, a lab reporting MRD should, for each assay and for each patient instance of testing, should at least, if they're reporting negative, they should report a sensitivity or a lower limit of detection for that
Right.
assay. So you know what you're dealing with, yeah.
At least.
Positive is positive, but negative, you have to know how deep they tested.
Okay. I'm not even sure if MRD testing is possible at all the labs in South Africa
Well,
that
Prof.
have.
Paul says here that they're doing 119 and 1221,
Yes,
so
yes.
that's good.
Yeah, the PCRs, yeah. We also did that in Albert Lutuli, so I think the PCR testing is definitely being done in pediatrics, where the patient does have a molecular marker up front. Yeah, it is being done. Yeah, I'm not sure about all the NHLS labs in the country, but certainly the ones in the larger centers are able to do it. Definitely. Any other questions for Theo before we close? I want to thank Theo for an excellent talk. It's always nice to have these talks that are relevant both to pediatrics and adults, and for all the wonderful references you've provided to us so that we can check back, or like me, I'll just call Theo and ask. So thank you very much, and thank you to everyone for attending. It was excellent, and see you next time. Thank you.
Thank you.
Thank you, Theo.
Thanks very much, guys.
Thanks,
Thank you. Bye.
Thank you.